So, in the interest of a very tight schedule, and we've got so much we want to achieve over the next 2 days, I wanted to welcome those of you who are here to the event. I will go through a bit of housekeeping. I know we are waiting for quite a few guests from the top parking, and it's a busy campus with a hospital. So, obviously, there are issues with parking. Welcome to Leo. Welcome, Cheryl. um, okay, so I'm just making sure everyone can hear me clearly. And I just wanted to welcome everyone to today's African Microbiome Symposium. We are honored to have guests joining us from across the continent, which was really a huge vote of confidence to this process, including Kenya, Zambia, and Madagascar, as well as from the US, Europe, various parts of South Africa, KwaZulu-Natal, and Johannesburg. So many friends and long-time collaborators. And then, of course, many colleagues from our local neighboring institutions in the Western Cape, Stellenbosch University, SERI, and the University of the Western Cape included. I'd also like to acknowledge the online delegates. We've got over 300 online delegates, and in sensitivity to them being able to hear what we're saying, we're going to be using roaming mics, and that's a little bit of the housekeeping later on, but just to be welcoming to the online delegates as well to the free webinar that will be taking place over the next 2 days. And your presence and commitment to coming here, I know for many of you, you've come a long way, is truly appreciated. And we thank you for taking the time for these vital discussions. So I'm going to start a little bit with some housekeeping generally, and some of the ecosystem guidelines. You'll see a lot of themes coming through around ecosystems and cooperation, but the restroom habitats are located just outside this room. For your convenience, tea and lunch will all be served upstairs where you would have entered the building, our central hub for refueling. And for those wanting to get continuing development credits to sustain your professional growth pathways, please ensure that you sign in for both days. We are aiming to maintain a low ecological footprint in the small ways that we can to this meeting. So we've opted not to go with disposable water bottles, and we've given glass bottles that you can refill with spring water. And this is part of a bigger initiative being driven by our Institute of Infectious Diseases to go green. And if your research presentation, which we are calling the ecosystem data flow, hasn't yet been shared, please connect with Matthew or Tanya or the AV people at the back to load your presentations. And should you need any assistance, you'll see spotted around the room. Adijat sitting at the back then. I'm sorry to put her on the spot, but anyone with that little logo around the back, we've got students and staff that are here to help you in any way if you get lost in this maze of an institute. So with that, I wanted to say welcome, and we really look forward to an enriching conversation this morning. Okay, so before we start, I just wanted to extend our heartfelt gratitude to the main sponsors for this event, which were our South African Medical Research Council and CIDRI Africa through the Wellcome Trust, as well as the Institute of Infectious Diseases and Molecular Medicine, because without their support, this event would not be taking place. So health research for women is neglected, and that will be the theme of this meeting over the next 2 days. And the consequences of this are disparities in understanding female-specific conditions, slow progress in developing effective treatments, and lack of personalized healthcare for women everywhere. Sorry. So how do we change this? Over the past 20 years, I've navigated the complex space of reproductive health, and particularly in Africa. And these are the strategies I believe will help us to restore the balance. This is why we are deliberately centering our focus at this meeting on reproductive health and on the vaginal microbiome in particular, and to better understand this critical ecological niche and its role in women's health. By extending our focus to the microbiome, we are acknowledging that health is interconnected across scales, from microscopic ecosystems to entire graphical regions. African biodiversity in all its forms is a vital global asset. Which provides unique ecosystems and species and genetic resources that contribute to health innovation. Yet a critical piece of this rich ecological puzzle remains underrepresented, and we're calling these, as others have before us, the missing African microbiomes. The absence of these African microbiomes in global databases distorts the true picture of microbial diversity, much like an ecosystem missing key members. And this imbalance hampers all of our health-related research and leaves critical gaps in undermining global health efforts. Integrating Africa's microbiome to restore balance to the scientific ecosystem will restore balance to the scientific ecosystem and enhance global health initiatives. So let's explore this potential for new growth. Focusing on these missing microbiomes will improve health outcomes through deeper understanding of how these complex communities of microbes living in and within us, within our bodies, interact with our health and cause disease. Just as every thriving ecosystem faces obstacles, the path to unlocking this potential is intertwined with unique challenges in microbiome research. I'm pulling out 3 important papers on which we're basing a lot of the thinking for this meeting, coming from some of the speakers that you'll be hearing later today, that have identified some of these gaps in this ecosystem, including local leadership, capacity building, coordinated intra-continental collaboration and networks, African national government investment in microbiome research, policy interventions, infrastructure developments, including next-gen sequencing. So the vision for this is for an interconnected global database abundant with African microbiomes, shaping a better future for human health on the continent and globally. Yet within these challenges, there's a really wonderful opportunity for innovation and discovery that can reshape the landscape of African microbiome research. It's about harnessing our collective strength and leveraging existing infrastructure and turning potential into progress. The microbiome is vast, and with diverse areas of research and impact. And the reason we're all here today is to identify where the greatest opportunities lie to collaborate. This truly it's truly inspiring to have such a remarkable group of experts in this room. And I'm truly humbled. So I'm very grateful for those who have traveled far and not so far to be here. Leaders in gut, lung, and vaginal microbiomes, champions of women health equity, pioneers in omics technologies, and visionaries who have set the scientific agenda across South Africa and the continent. We are also joined here today by government leaders, partners, and community engagement specialists, all of whom have been essential in building a robust ecosystem for African microbiome research. We brought everyone here today to map out a comprehensive strategy for accelerating this field, not just for South Africa, but across the continent. Imagine a network of microbiome research hubs flourishing across Africa, from Kenya to Zambia and beyond, connected by shared knowledge and resource. Let's use these 2 days to craft a vision that takes a holistic approach to microbiome science, driving forward collaborative, equitable health systems and transformative innovation. To frame this conversation, it's essential to recognize that our efforts build on strong foundations laid by African governments who strongly support and invest in our institutions, such as the one we're sitting in today, through infrastructure development, funding for research, as well as critically capacity building. As we move forward, I would like to focus on key aspects that fall into 2 broad categories. The first being local scientific leadership, including that this is necessary to drive a robust research ecosystem, to ensure coordinated intra-continental collaboration and networks, prioritize which infrastructure we need critically to develop, and train and importantly nurture the next generation of African scientists. And secondly, but one piece can't go without the other, is African governments and their role to commit to further strategic investments in microbiome ecosystems, to promote policies that accelerate ecosystem building. So Africa is well positioned to lead this charge on reproductive health research with innovative, locally driven solutions that address global health challenges. So with this momentum, we are taking a bold step forward today with the launch of our new lab, the Microbial Interactions Lab, to accelerate microbiome research in Africa, to celebrate the continent's unique microbial diversity, and cultivate thriving research ecosystems that foster innovation and collaboration. We eagerly anticipate discussions with each of you this week. And importantly, we see these as an opportunity to chart a course and harness our collective strengths to nurture a thriving ecosystem that advances our shared vision. So with that, because this meeting is about to start, I wanted to introduce the 3 keynote speakers that will be opening our meeting. I would want to welcome and introduce Professor Elizabeth Bukusi, who is the Chief Research Officer at the Kenya Medical Research Institute and a Distinguished Fellow of the African Academy of Sciences. A leading voice in championing gender and equity in African health research, Professor Bukusi has made significant contributions through her work that has shaped global perspectives of of HIV prevention. And just for those who may not know, Professor Bukusi is our vaginal Microbiome Research Consortium for Africa partner together with Surrogatommy. And I'm very grateful that they made the effort to come. It is also a great honor to introduce Dr. Sharon Achilles from the Bill and Melinda Gates Foundation, an incredibly valued partner in all of this, and a global leader whose work is setting the standard for transformative research in seeding innovation and reproductive health. And I'm honored that you made the trip to come and be with us today. And I'm thrilled to introduce my long-term collaborator and really important mentor, Professor Linda-Gail Bekker, who's CEO of the Desmond Tutu Health Foundation and past president of the International AIDS Society, an HIV prevention pioneer and inspiring leader who will share insights on women leading the way and cultivating change, which I think is the perfect title for anything you have to say, which aims to highlight the transformative impact of women at the forefront of health innovation. So with no further comments from myself, I'd like to invite Prof. Bukusi to set us off on our exciting 2-day journey. Thank you.
Thank you very much for that extremely kind introduction. I almost feel like I've been set up because to be put on the same speaking panel with the next two speakers is really challenging because whatever you do, they're going to better you. But I want to start by saying that over probably now 27 years ago, I went to the University of Washington to start a master's in public health, and I had the privilege of being mentored by Professor King Holmes. Now, I was later to discover that for a long time, King had been trying to get one of his mentees to do a particular project that was a pet project of his. And King was one of these visionary leaders who always saw things that others hadn't seen. But he hadn't been able to convince anybody to do that particular study. I came along and, King was this amazing person who you get an opportunity for him to mentor you, and it's such a privilege and an honor. So as we talked with King told me that one of the important things we needed to do was to understand why it was that in the parts of sub-Saharan Africa where there were many men who were not circumcised, with bacterial vaginosis, and it also seemed to be linked in some way to new HIV infections. And he'd been talking about this for a while, but nobody had quite bought the idea. But what he convinced me to do was, why don't we try and see whether can we get men to wash immediately after sex, especially uncircumcised men, and see if this would make a difference to the recurrence of bacterial vaginosis. And of course, I bought the idea and earned myself the title of being the Willy Wash Lady. Needless to say, King was ahead of his time. Later on, we were able to demonstrate that voluntary male medical circumcision did make a difference, clearly showing that there was something there that was contributing to recurrent BV and was contributing to the things we're now thinking about when we're thinking about the vaginal microbiome. He did have an idea. Just to finish that story so you don't go home wondering what happened, it was very difficult to get men to wash after sex, especially in Nairobi, cold water, in the middle of the night, no way. Very difficult. We did try some other products, and that's another story you can ask me another day. But today I want to talk about the issues of how do we define gender equity, and especially when we're thinking about in health and research. And I think about it in 4 big buckets. That it's not just about the research output, but it's also about capacity building. And it's about partners and partnerships. And we also need to be very clear about the resources that are brought to the table to make this a reality. Let me try and illustrate this by a few stories from our own research network. I want to start with the story of this young lady who's called Atieno. Atieno is a name that's very common in the part of the world that we work in. Now, Atieno got excited because he got married, but as a second wife. Not uncommon in that part of the world where polygamy is something that still continues. But when Atieno got married, she didn't realize that the reason she got married as a second wife was because her husband had not been able to have children with his first wife. And of course, as always happens in that part of the world, not having children is the problem of the woman, not the man. Well, thankfully, Atieno did start bearing children. But then she realized she didn't have any equity in that relationship. She didn't have an opportunity to voice anything that she wanted. Her relationship with her husband was purely around the next child and the next child, limiting her opportunities to be able to be in a place where she could take care of her children herself because she was completely reliant on him. And the first wife, who had happily accepted he could marry a second wife, had all the power and all the say in that relationship. So her health and her concerns, something that were completely out of her control. And sometimes we think, oh, it's because women aren't empowered and they don't have education. That's what makes a difference. Unfortunately, sometimes that's not the only thing that makes a difference. Because when I think about someone like Awinja, who's a college student and a 21-year-old, who has actually been someone who walks into our research clinic, she has a boyfriend and he doesn't want to use condoms. So because she feels she can trust him, she accepts. And for her, it's very important to have a boyfriend. Yes, she's in college. Yes, she's getting an education. But this relationship also means something to her. Now, we've treated her with recurrent infections a number of times. We keep saying to her, it's important that you get some protection. Her boyfriend isn't buying this. And so it's very difficult for her to insist in that space. And so she remains at risk, not just because of the changes in her vagina, also because of the risk that she's putting herself to. In the area that we work in, we have a lot of HIV. But maybe you're thinking, it's really about women who are not that empowered. But I really want to emphasize the issue on equity. Because for Frida, who's actually a PhD student, similar challenges came up. Frida had an opportunity to be able to take up PhD studies. But guess what? The opportunity did not give her the support that she needed. She had a young child. The PhD didn't offer her the support to be able to take her child with her or to be able to get childcare opportunities. Frida did not want to leave her child behind, so she opted to go with her child. It became so difficult for her because in order to try and get her work done, the lab needed her to work at night. The caregiver could only be there during the day. He didn't have extra finances to be able to get anyone to work with her at night. She couldn't travel someone else from home to help her take care of the baby. Even getting visas would have been a challenge. So she didn't have the support to allow her to achieve all her goals, not just educationally, but even as a mother. This really contributes to the fact that we have a challenge with research output world over, and especially when it comes to female scientists, that we end up lagging behind because we don't get the support that allows us to be able to do all the important things we need to do. As an OBGYN, I am passionate about women's research, especially in reproductive health. And I keep thinking, if women don't reproduce, we will be extinct. We will die out. Reproduction is such an important part of ensuring that we can remain on this earth. But when you think about us as Africa in a continent as well, and this is a famous map that you've probably seen, we are never quite represented as we should. The maps show us to be smaller, and the rest of the world makes us feel even smaller than we are. And then sadly, we don't use our resources in the way that we should to allow us to occupy space in the world that we truly should be. Let's think about infrastructure, and especially when we are talking about the complex research that's required. The microbiome research that we're talking about today, this is so critical. We really cannot compare. When you think about laboratories that are in many parts of sub-Saharan Africa, you can't compare them to the labs that are available elsewhere. And what are some of the things that contribute to this? I keep thinking about overheads. I have the privilege of being associated with the University of Washington and a number of other universities. And if I put in a grant from the University of Washington, UW will get 40 to 45% overheads. If I put in a grant from Kemry, the maximum we can ever get is 8%. We can't compare the labs at Kemry to the labs at the UW because we don't just have the financial muscle to be able to do the same thing. So there is inequity there that's been very, very difficult to address. I think I'd be preaching to the choir if I talked about all the different ways in which microbiome research is important, all the different areas, some of which I know the experts in this room know so much more than I even do. But we cannot emphasize and overemphasize the importance of this kind of research because it is a game changer and it is going to make a difference to how we do work and how we make a difference, not just to the women of this continent, but to the people of the world. So where do we go from here and what do we do? I think a lot has already been said and Jo-Ann has so beautifully stated already. So I cannot even match what she's talked about in terms of what we need to do. We do need to make a difference. We do need to bring strong collaborations and partnerships from this part of the world, but also from elsewhere, for us to be able to make a difference, for us to be able to work together in a joint effort to allow us to be able to create equity, be able to leverage on these partnerships, to ensure that we have standardized technologies that can be replicated in very many different setups. We need the institutional and the government and other partners' support for us to be able to do this. My last point, because I was asked to talk about issues of equity, it is a very, very critical part of our development. And I think we need to come to the table with adequate empathy that allows us to find solutions that we can co-create together. And we need to ensure that we're involving the very people for whom we want to get this work done, because it's only in that way that we together will be able to make a difference. I want to end by sharing with you a poem that I learned, and I won't recite it because I've recited it in many other forums, and I don't want to repeat it yet again. But it's a poem that was written early in the early 60s when Kenya came into independence. It's called The Freedom Song by Marjorie Achilles. Marjorie was a woman who grew up in the United Kingdom, got married to a Kenyan and came and lived in Kenya all her life and died a few years ago in her 80s. And she writes this poem where a young girl who doesn't get a chance to go to school, but works as a nanny or as a housekeeper in her uncle's house from the age of 9, sleeps in the kitchen, does a lot of household chores, desires school but doesn't get the opportunity, barely has a salary, barely gets enough to eat, ends up getting pregnant while she's a young teenager, 14, rising on 15, dies of postpartum hemorrhage. And guess what? At her funeral, there's celebration, there's a lot of food that she never ate in her own life, there's lamenting at the loss of her young life. She leaves behind a child who survives. And the story says this child may repeat the same cycle of this young lady's life. And the sad thing for me has been that while this poem was written in the 1960s, 50 years ago, when Kenya became independent, the story remains true today. And the Latinos that die now still die of postpartum hemorrhage, but they also die of HIV infections. They also end up with sexually transmitted infections that they cannot get cured. They suffer the same ills, and that we repeat the cycle over and over again. I think the research that we want to do has an opportunity to make a difference to the Latinos of the world who live not only in sub-Saharan Africa, but in many different forms in many other parts of the world. So I hope that together we can make a difference so that we won't be repeating this cycle over and over again in another 50 years' time. Thank you for your attention.
Thank you, Prof, for that very powerful keynote address. We're going to not be taking questions after each speaker, but at the end of the session, we're going to invite the three panelists to come to the front and we'll invite questions there. So I would next like to invite Sharon Achilles.
Thank you, Joy. Good morning to all of you in the room and welcome to everybody online. It is a real honor to be invited to give this talk this morning and to be on such a distinguished grouping here. It's so hard to follow you, Dr. Bukusi. I don't have such an impassioned discussion in my slides today. Really, I thought what would be most useful is for me to describe sort of a little bit about the structure of who we are at the Bill and Melinda Gates Foundation, the strategy that we're deploying against the problem of vaginal microbiome, and a little bit of discussion around where we think the importance of all of us working together on this problem. And yes, the African continent is an enormous source of diversity that cannot be excluded from this. We do so at our own peril. And so I really appreciate the opportunity to discuss this with you today. I wanted to start off with this chart, which shows dailies, the discovery or the disability adjusted life years. So diseases that impact men and women. The line on the x-axis that's represented with the red line at 1 is when diseases affect men and women equally. Everything to the right of that is diseases that affect women more than men. And then the y-axis represents the dollar amount that goes towards research against these diseases. And as you can see, there are many conditions that affect women more than men. And those generally are research dollars that go towards those diseases are generally much lower. And so we do have an inequity in knowledge generation around diseases that affect women. And this is, a historic fact that has resulted in far less understanding and far less tools to help with health for women relative to men. At the Bill and Melinda Gates Foundation, we recognize this problem, and for that reason, a new division, which are the large pillars at the foundation, was formed a few years ago called Gender Equality. Within Gender Equality, there's a group called Women's Health Innovations. This is the group that is mainly responsible for research and development around products and infrastructure to support women's health. That is broad and includes infectious disease. It includes all kinds of health issues that impact women greater than men. And it also includes economic considerations and supporting women because there's inequity there. I've represented on here all of the pillars that are associated with women's health innovations. And just to orient you, I am the Deputy Director for Reproductive Health Technologies, which sits in a different division in the foundation. But we are the discovery arm, and these blue shaded boxes are all the work that we're doing. So we're the discovery pillar, essentially, for the Women's Health Innovations group at the foundation. I know that we're very opaque at the foundation. It's hard to understand our structure. So I always think it's helpful in these audiences to try and orient you to who we are. It helps with everyone who has ideas to bring to us so that you know who the right person is to bring them to. And if you don't, please reach out to any of us and we'll be happy to direct you along the complicated map that we are. So in Reproductive Health Technologies, the group that I am leading at the foundation, we are really seeking to holistically consider sexual and reproductive health needs For women globally, and we have a particular focus, as does the entirety of the Bill and Melinda Gates Foundation, for people in the global south, in low and middle income countries. And so we're investing in discovery towards development of technologies with potential to improve health and well-being. We in Reproductive Health Technologies have two existing major initiatives, the biggest of which is around vaginal microbiome. And that's why I'm here today to discuss this with you. And I'm going to spend most of the rest of the talk talking about the vaginal microbiome interventions. But I did want to mention also the other portfolios that we have in Reproductive Health Technologies and to start thinking about how they are all really interconnected. They're all part of a web that relates really to vaginal microbiome. So we have a portfolio around cervical cancer prevention. And I know, we have a vaccine for HPV. It's the best vaccine that's ever been made. It has amazing efficacy and durability. And the problem that it's facing is scale up. It has not been effectively scaled in order for us to realize the impact that this vaccine can have. If this vaccine was scaled to 90 to 100% of coverage today, there will still be 50 to 60 years of a gap with people dying from cervical cancer because that vaccine, although highly efficacious at preventing high-risk HPV infection, does nothing for people who already have that infection. And so we are working on developing a T-cell mediated vaccine to clear out high-risk HPV infection that's already existent in order to address that residual burden of HPV while we await the amazing impact potential for the prophylactic vaccine. We also have an initiative around menstrual health knowledge and innovation. This relates to the historic non-focus on women's health in research. There are tremendous knowledge gaps around the mechanisms, biological mechanisms within the female reproductive tract and the drivers of health and disease for women's health. We really have, this is a small portfolio right now, although there are large gaps. We are mostly focused at the moment on things that directly relate to other items within the foundation strategy. So vaginal microbiome is a big one. We're interested in understanding the causes of vaginal dysbiosis, particularly do menstruation and menstrual hygiene practices impact the vaginal microbiome. We're very interested in understanding differential bleeding responses to continuous progestin-only contraceptive use, because we know that the main drivers of non-use of contraceptives and discontinuation of contraceptives is because of bleeding patterns that are really disruptive to people's lives. And then finally, we have a project around understanding uterine peristalsis patterns and how those relate to health and disease states within the reproductive tract. For syphilis, we're still in a very early stage that we call a learning agenda. It would be fantastic if we could develop a global vaccine for syphilis. However, we don't know enough yet around the genomic diversity of Treponema pallidum, especially from the global south. All of the genomic information that we've had has come from the global north. And so the past couple of years, we've been trying to fill those gaps and gathering primary syphilis isolates from low and middle income geographies in order to do whole genome sequencing and think about whether or not making a global vaccine to syphilis would be feasible. So these are in active discussions at the foundation. I now want to pivot to the vaginal microbiome and introduce our Vaginal Microbiome Research Consortium. This is a picture of us taken at our meeting in Dakar a year ago, just about right now. This is a group of mainly academic researchers at the moment that are working on the problem of vaginal microbiome. This is again the graph that I showed in the beginning, and here I've highlighted in pink boxes all of the conditions that are likely linked to vaginal microbiome. Vaginal microbiome is foundational. It is the soup in which everything happens within the vaginal and likely upper reproductive tract space. And so really defines the environment and defines a lot of the outcomes if exposed to a pathogen. So it's really critical that we get this right. A dysbiotic microbiome is associated with increased risks of adverse pregnancy outcomes, with increased risks for HIV and sexually transmitted disease, acquisition, and transmission, and increased risk of progression of human papillomavirus from just infection to precancer and cancer. Whereas a healthy microbiome really minimizes these risks, even in the presence of exposure to a pathogen. I put on here also some pictures of water, just because I think a lot of people don't really have a true visual understanding of the differences between a Lactobacillus crispatus dominated microbiome versus a diverse anaerobic space and what it would be like to be in that environment. So a Lactobacillus crispatus dominant microbiome is kind of like this clear mountain stream that you see on the right-hand side. Swimming through that, there's not a lot of bacteria around, relatively speaking, versus a diverse anaerobic environment is like this swamp picture over here, where there's a lot of bacteria around, there's a lot of different species, and it's really crowding the space. We're working on designing a product that will impact the transformation from the diverse anaerobic state to the healthy state. I just put here for informational purposes, and I'm happy to share these slides for you to digest further, but our high-level summary of our target product profile for a vaginal microbiome product, including minimum criteria and optimistic. This is still in development, so still a conversation. I don't think this is perfect by any means, but we put it up here to start the conversations. Our program objectives are really to work towards establishing a Lactobacillus crispatus dominant colonization by removing the diverse anaerobes, establishing space for crispatus to become dominant, and then to support those crispatus for a durable effect. I'm hurrying up because we're running out of time, so I'm going to go quickly. I know there's a lot of our vaginal microbiome research consortia partners here, so they're familiar with what we've been doing. But the high-level view is that we have started by taking Lactobacillus crispatus strains from women in diverse areas, some women from North America, some women from South Africa, and other regions within the African continent, and selecting strains so that the metagenomic diversity is optimized. We've taken 6 of those strains, which gets us to sort of the asymptote of metagenomic diversity, and put those into a tablet. And then we've taken 15 strains and put those into another tablet, which sort of gives us some duplication of the metagenomic diversity. These tablets are not designed as a product per se, but rather as something that we can use to test and understand the colonization kinetics when we use these in women after they've been treated for bacterial vaginosis with metronidazole. So we're gathering data because we don't have an animal model and we don't have adequate preclinical models to test it any other way. This is the design of the Vibrant study, which is being conducted currently both in Boston and here in South Africa. The enrollment for this will be closing in the next few weeks before the end of November. And we're very eagerly anticipating data from these studies so that we can really understand these colonization kinetics of these diverse strains of Lactobacillus crispatus. We then also think that just putting the crispatus into the vagina is not going to be enough. And we will need to do some further components that both decrease the anaerobic diversity and tilt the scales towards favor of Lactobacillus crispatus. And we also probably need to support those crispatus so that we have durability in that new vaginal microbiome environment. I'll point out here that all the arrows are pointing towards one formulation. I don't think that's necessarily accurate. I think we could do a multi-component formulation in one product, or I think it's equally feasible and maybe beneficial to have separate products as well. And we can discuss that, but we're still open to multiple ideas here. And then the last two slides of data are just describing some of our cohorts. We have cohorts across geographies in non-pregnant people as well as in pregnant people. And these outline all of the samples and what we're testing them for across our investments. And so I put these here for informational purposes. And like I said, I'm happy to share the slides so you have some visibility into all that we're doing. I'd like to finally conclude with just acknowledging that we have a lot of knowledge gaps in the biology associated with vaginal microbiome and women's health in general. We also need to acknowledge that we have a lot of cultural gaps in understanding how is it that we make a product that's really not only acceptable for use in diverse populations of women, but desirable for use, because that's how we really make impact, right? Product that people want to use, maybe that they don't even need to know what their vaginal microbiome is doing, right? But if the product gives some other benefit that makes it desirable for use, I think we could really have we could amplify the impact. And so I want to raise that because I hope that we are able to talk through some of that and acknowledge these gaps so that we can start working towards addressing them. So thank you.
Thank you for giving us that big map of the landscape. That was really useful to frame the next couple of sessions we're going to have. So thank you for that. And I want to invite Linda-Gail up for your presentation.
Thank you. Hi, everyone. Real pleasure to be here. I want to thank Jo-Ann and the team for the invitation. So nice to see so many good friends and collaborators and others. And I am unapologetic a woman and HIV standpoint. And I'll be making a case for that, hopefully, and really end with a big question mark as to which I think is being answered in these next couple of days and over the next few months under Jo-Ann and the team's leadership. So in 2023, of almost 2 billion youth globally, 4,000 died every day, mostly from preventable causes. Most of the DALYs lost in adolescence are attributable to sexual reproductive health causes, as already mentioned by Sharon. And in this week, 4,000 adolescent girls and young women aged 15 to 24 years became HIV positive. Over 3,000 of those young women live in sub-Saharan Africa. Juxtaposed, an estimated 1 million people incurred an STI, a curable STI, every single day. Now, I am not an expert on bacterial vaginosis. I've been learning an amazing amount from our collaborators here at the IDM. I'm an infectious diseases somebody. So, these pathogens are what I've focused on, but I think what I'll illustrate is just how this really lends itself to strong partnerships. So where are young women in sub-Saharan Africa today? Well, just going through the sort of portfolio of the 200 million that are in sub-Saharan Africa, more girls are completing primary school than boys, but tend not to complete secondary school. Of course, we know gender-based violence is something that really dogs the landscape for us, particularly in this country. Largely, young women are unemployed. Youth unemployment in sub-Saharan Africa is double adult rates, and adolescent girls are far more vulnerable in this space. And then turning to the sort of infective problems on the left-hand side, young women accounted for 53% of new infections in 2023, far more than their male counterparts. 80% of them live here in sub-Saharan Africa. Undiagnosed STIs contribute to morbidity and reproductive failure, and 50% of rural young women have been pregnant before the age of 18 years, millions lacking access to modern contraception. And, I can go through just how we have not been able to really move the needle on incidence in this population of young women and girls. Although we've seen rates come down, we've come from a very high bar. And so we still see, rates of 7.4 in this study looking at the fears that Nora Rosenberg has just published. Of course, in South Africa, over it's a number of years, we saw an incredible increase in HIV to a very high rate, highest in the world, of more than 8 million adults living with HIV. And when we look back even, more than a decade ago, this was already a feminized epidemic, which has continued. And so when we look in South Africa itself, again, really disturbing high incidence rates, leading to, Chris Byron and a few others, perhaps somewhat provocatively, putting out this statement just recently. Can we really think about epidemic control by 2030, given that we continue to see these sort of rates? So, Tulio, this is in your honor. Whether you believe in age-disparate sex as a cause, a driver for HIV or not, it definitely is a situation where young women are becoming infected by men who are not in our systems, perhaps, therefore are not on antiretrovirals, are not virally suppressed. This leads, of course, to vertical transmission still continuing, and this vicious cycle, which was so beautifully described through science in 2016, thanks to Caprisa. And if we think about the vulnerabilities in a little more detail, along with everything we know, unemployment, GBV, limited agency, older partners, non-responsive SRH services, STIs, perinatal infection, what about vaginal health and dysbiosis in this setting? And that really is the question in the next couple of days. Sharon and I were just discussing how this is kind of the unspoken elephant in the room. I don't hear in HIV circles this link to vaginal dysbiosis really being articulated to the extent that it should. And I think it's the continuing denial of women's health, vaginal health. It's a subject we just don't even want to interact with, even in the HIV circles. And really, we need to understand this when we're trying to think about where do we intervene to break this vicious cycle. And I would say that if we continue to disregard sexual reproductive health for women, and I would throw in there also mental health, because I think this comes into it, and their economic empowerment, their livelihoods, their equity, essentially, then we will continue to see ongoing morbidity, mortality, not only due to HIV, but many other problems. And this really is where women are falling through the cracks and somewhat missing in the data. So when we rethink the vicious cycle, where are the places we can interact and make a difference? And here I want to think about the need for a tailored harm reduction approach that takes into consideration biomedical as well as behavioral and structural responses. So on that score, I am an HIV specialist and I care a lot about biomedical interventions. So can a pill a day prevent HIV? Indeed, yes. We have now, I think, shown through really good clinical research that a pill a day can prevent HIV. A little bit of a difficult start in the beginning. And again, I think this speaks to how we approach women in our clinical research, etc. We may not have had a good start to understanding oral PrEP, at least in this setting, or vaginal rings in this setting. But subsequently, we have gone on to show that when oral PrEP is rolled out, we start to see impact. And finally, despite the fact that these studies were done now in 2010, FDA approved in 2012, WHO approved in 2015, we now have upwards of 6 million people having initiated oral PrEP at least, somewhat off the targets we need. We're hoping for 10 million at least on oral PrEP by 2030, and you can see we're sort of moving in that direction, but certainly have a long way to go. Do you want to say, thankfully, our region is now finally making a significant contribution, and you can see South Africa, hats off, finally now really adding to the impact, but Zambia, Uganda, Nigeria, and of course Kenya was a wonderful early adopter in this regard. What we're hearing from young women is that now I have, unlike that Tino and others who struggle with asking for a partner to use a male condom, they now have the ability to actually take their own sexuality into their own hands and be in control, as it were. However, this is not without challenges, and many of these challenges come in the form of, again, societal, structural barriers. And we know that we've struggled with oral PrEP, with uptake and persistence. And this is still some of the barriers we have to overcome, that although it can be perfect for some, for many, oral pre-exposure prophylaxis is not the exact answer. And many of you will know that we have moved on happily to injectable pre-exposure now and vaginal pre-exposure, which means that people can dose less frequently. And hopefully we'll start to see with choice that this begins to improve. But not to give up on this. This is data now, just for those of you who may not have seen it, from Jeannie Marazzo, where she looked at a large number of people who have been in cohort studies and shown that maybe adherence doesn't need to be quite so perfect, that even 4 doses a week definitely makes an impact on incidence. And even in those high but declining, we see some a 50% reduction in HIV. So the HIV prevention train, as I like to think of it, you pull up in your station, you use the prevention you need, pre-exposure really coming into its own now with a very nice array of opportunities from a monthly ring, 2 monthly injectables, and now finally 6 monthly injectables. The monthly ring going on now to show that we can use 3 monthly rings, and maybe we can even add a contraceptive. So again, starting to really speak to what people need. And here are some even more exciting, a ring into which any kind of product can be put, even something that could take on an STI. So we're starting to really get innovative. The 2 monthly injectable now being moved to 4 monthly injectable. And those of you who watch the news, as I say, you will have seen that the 6 monthly injectable looking very exciting. Combining oral PrEP and oral hormonal contraception is a thing and is actually moving into phase 3s now. And this product hopefully will be very exciting. So as we start to look at the opportunities on the left-hand side, you can see in development patches, enemas, vaginal gels, and preventive vaccines still in the making. There has been provocatively raised that pre-exposure prophylaxis, however, is causing a lot of condomless sex and an upsurge in STIs. And I love this particular paper by Janelle and Jared Baton, where they sort of turn it on its head and say that it really is an intersection and an opportunity. Because certainly we know, and this is a study, I'm going to go through a couple of studies which really illustrate that we've done in partnership with Jo-Ann and the team, that have illustrated that actually STIs have been with us for a lot longer than pre-exposure prophylaxis. So condomless sex definitely predates pre-exposure prophylaxis. STIs are frequent and, importantly, frequently asymptomatic. So unless you look for them, you don't find these problems. And this is one cohort study done in Massapomaleli where you can see extraordinary rates of bacterial STIs, chlamydia, gonorrhea, trichomonas, and up to almost 1 in 2. Here you see it, both the WISH study, a meta-analysis, and another study we've done just recently, which really shows extraordinary rates of untreated STIs, most of them asymptomatic amongst women. This is the INSIGHT study conducted in a number of sites around sub-Saharan Africa, and again, just the extraordinary rates in Cape Town, with also high rates of viral STIs. This is another one of our collaborative studies, the MISC study, looking at the role of STIs, HIV, and gender-based violence, as well as vaginal health. And you can see adolescents were more likely to have STIs than adults. They're more likely to report earlier sexual debut. Young people in KZN more likely to use intravaginal products. But again, these extraordinary high rates of STIs. And this study, the U-Choose study, I use it to illustrate not only, again, high rates of STIs, but the opportunity working with the mucosal team to look at the biome, not only at the vaginal, but also in terms of children and all the way through to, vertical transmission and the impact on reproductive health. So this was a study where we asked HIV questions, but we were able to very nicely interact around the vaginal health and well-being. And then finally, I want to say there are still ongoing operational questions we're asking. We find that point of care STI treatment isn't entirely easy because it isn't point of care. This moment, it's 90 minutes. We've done everything from getting people to wait with internet coverage, sending them the positive results, couriering their treatment to them, but we are still seeing incredibly low rates of treatment of STIs. And again, I want to say this is because they're asymptomatic, and maybe it's not not necessarily filtering through to young people. I already mentioned that it does take two to tango. It's an old adage, but it's a real adage. And here, Nigel, this is your work, that we have to bring partners into the game. And how do we do that? Of course, a lot of infection is reinfection. And unless we treat the partners and interact, and how much of the biome is also part of the partner. And then not to forget that alongside, and I agree with you, Sharon, that maybe a treatment we can just give to people, but I think we empower young women if we help them understand their vaginal ecosystems, and we bring them on board. And I'm shocked at how little is understood about vaginal health, STIs, We've done a great job on HIV, but we are lagging way behind in terms of STIs. And so we have really been trying to work through what demand creation looks like to really get people up to speed on STIs. So STIs are highly prevalent amongst adolescents in our communities. There's a worrying increase in syphilis and congenital syphilis worldwide, but also here. Bacterial STIs are most often asymptomatic. They're not well understood and awareness is low, therefore low incentive for care seeking. STIs can and should be part of SRH and HIV prevention. Differentiated services enable STI care. STIs can be screened for and treated in the community. A 90-minute test is not a point of care, Bill and Melinda Gates, so we really need something more than that. It's not your fault, but we need you to come up with something. There is a serious leak in treatment cascade when results are the next day, and you haven't cracked partner. Young people are telling us what they need. They're saying they need fast and efficient, transparent services. So we need to think about how we do this, and this is part of it, to really understand how we provide sexual reproductive health services to them. They are not in the clinics. They're everywhere else. How do we reach them? And so I want to say we have to think about the demand creation, where we find them, how we reach them in where they are, and come at this in a seronegative way, where a seroneutral way, where we come both for prevention and treatment and offer them services that take into consideration their sexual, reproductive, mental health, and wellness. And finally, my provocative final statement is not to forget the bummock in the ocean sitting beneath the observable, the interaction between asymptomatic STIs, inflammation, the vaginal biome, and female well-being. Interaction between STIs, inflammation, vaginal biome, and HIV susceptibility. Interaction in the context of the life course, endogenous and exogenous hormonal shifts, and the impact, and here I want to bring it back, the impact of the above on HIV prevention effectiveness. So we're doing all this work in biomedical interventions. How much are they impacted in terms of, their effectiveness due to the biomes? And I'll stop there. Thank you, Jo-Ann.
So I wanted to invite our three panelists to take a seat, and we've got microphones to give to each of you, and I invite people to start thinking about their questions, and we've got three of them. So do we have any questions for panelists? I just wanted to say, while we're waiting for questions, that Linda-Gail, I think the messaging around HIV prevention framed was really important in the discussion, because as I've been part of the Vaginal Microbiome Research Consortium, that feels like it's how we got into this particular field, was through the HIV lens, although I think Sharon did an amazing job of framing the broader context. Vaginal microbiomes impact all facets of life, but we're seeing it from a very lensed approach. So yeah, thank you for that. There's a question at the back. Just as a housekeeping, we've got over 300 people online, so we just wanted to have all the questions going through the microphone.
Good morning. Thank you very much for those very interesting points of views. I do perhaps have a two-part question. So we do work with the African cities. We have done a number of trainings at Kimberley. We work with George Kagenji, Jim Juma from ORI. So we do see this diversification of large group of people, but we're really struggling with, this financial there's financial barrier of entry, there is language barrier of entry, there's culture barrier. When we're trying to train people and disseminate knowledge to empower these individuals, there's always that gap and skill set that we can't really translate, properly into training. So I really want to understand from your perspective, how do we go about to give, better training, and how do we methodically develop a process to ensure there's fairness, there's equal opportunity? And then perhaps the second question to the Melinda Gates Foundation is, the WHO and the World Health Organization have all said, by the year 2050, a quarter of the world's children will be in Africa. And at this end of the century, half the world's children will be on the African continent. That is a huge, huge number of people. How do we go about to ensure that, proper knowledge and opportunities are given to these individuals so they're not, burdened by disease, and they're actually able to contribute to, science and advancement of human society? Thank you.
So who wants to take the first question, Prof?
Maybe,
Yes.
Maybe some clarification, because when you talk about the groups that you're collaborating with and talk about a language barrier, I'm wondering where the language barrier is, simply because the kind of collaborations you're describing, Cambry, Ilui, I would assume that those are people who have already had some level of training, perhaps graduate degrees, diplomas, masters. So I'm not sure where the challenge is in terms of the translation to language. Where I can see language barriers is when you're dealing with community and literacy within the community, because some words are very difficult to translate, and there isn't a direct translation for some of the terminology that we use. And so you need descriptive terms to be able to translate those. But perhaps where, again, there may be a challenge when you're thinking about training, it's just the opportunities in order to train. But I take it from the point of view of we do not have as many lab-based scientists who are doing lab-based innovative work in this part of the world as we could have. And partly it's because of the opportunities to train. We may do a lot of diagnostics. So when you're talking about innovation, and really doing lab work that's de novo, that's finding these new point of care tests that are not 90 minutes long, we are not creating those opportunities for people to come up with those kind of ideas. So perhaps if you clarified a little bit about the language, I may be able to answer that better.
And Sharon, just to follow on, do you want to deal with the question?
Sure. Is this on?
Yeah.
It is? Okay, good. It doesn't sound like it's on from here. Anyway, I don't know that I have a real answer for you in terms of the population explosion that's projected for the African continent. I will make a couple of comments that I think that the African continent is particularly poised to make major advancements. The human resources that you're alluding to in terms of what's upcoming, the economic resources that are coming in today's day and age of AI and everybody having a cell phone in their pocket, there's really more opportunity to interact with the world and apply the diversity of the African continent to the thinking, which will drive innovation. And so I think that the African continent is really poised to make, leapfrog advancements in the coming decades.
Yeah, I'll just add, if I may, Jo-Ann, I think it is about opportunity. So, I think we have been very much framed as the place where you come and do phase 3s, or late type clinical research. And I think we're retelling that narrative. First of all, African researchers want to be there from the get-go. We want to be involved in discovery, not only development of new R&D. And I think we're starting to see some of that. And the opportunity comes not only in terms of recognition and awareness, but also funding, right? So when we get access to that R&D funding, there is no doubt in my mind that we can play a significant role. And here I want to, draw attention to the fact that even in vaccine research, where there is HIV vaccine research, where there is really difficult lab science that needs to be done, it is being done in a lab in Kenya today, even, when it's sort of Western antibodies or whatever that we're needing to make. Eunice and Duarte's lab is the lab where this is being done at the moment. And, I want to sort of draw attention to the new Brilliant Consortium, building on the Advanced Consortium, which came out of Kenya, that we really are moving this forward. So I have absolutely no doubt that, with your new impetus here, Jo-Ann, we're going to see this kind of R&D happening right from the earliest phase all the way through. So I think these opportunities are just great. And I want to pay tribute to the Gates Foundation for allowing some of that recognition to happen on this continent, and really want to see more of it if possible.
Yeah, absolutely. The partnerships are very important. There's Chantel and Nigel and Disebo.
Thank you so much to the speakers for your beautiful talks this morning. It's very clear that vaginal microbiome is very important for female reproductive health and for females with regards to infections and HIV risk. It is also very clear that men play a very important role in this, because this is, sexual interaction, and it's a risk for BV and other infections. And I'm just wondering, if women go to clinics and women are being educated, but women are not in a position to talk to their partners about sexual health, about symptoms, about issues, how are we addressing this issue, and how are we actually educating men? And why would men really be interested in actually bothering if they're not educated? And I just wanted to know, what are we doing about that?
So what are we doing about the men? Everyone's handing the mics.
So I'll pick it up. I think all of this is transactional. I'm somewhat cynical about this. So there is no doubt that you have to make men aware of the benefit to themselves, and there are benefits to themselves. I'll illustrate. HPV, and you're absolutely right. The value of the HPV vaccine, even in our country, we're only giving it to girls, right? But we did a study some years ago now to see, could we use HPV as a kind of surrogate for how an HIV vaccine might be taken up? So again, the interactions here. And we went to girls, and girls got it right away. Yes, please, I would like an HPV. Went to boys, and they were like, no, a needle. Why would I show? We showed them a picture of a viral wart, and immediately the hands were like, yes, I'll have that vaccine. Thank you. So my point just being, and I think it is about, taking, and it doesn't always have to be a loss frame, right? I think the U=U message at the moment is a powerful one, where we can say to people, here's the value for you, and here's the value for your intimate partner. And so, we need to find those kinds of ways of transmitting good information, and spend time. And then also involve these communities to ask them what really works for them. So I hinted that, there is work to be done in this area. And I think, Nigel's done some of it. There are other people, really trying to understand this. I think this is work to be done.
Allow me to bring it from a grandmother and a mother's perspective. I raised 4 now grown men. I had the responsibility of making them responsible for taking care of their lives and their sexual lives and the lives of their partners. And I think mothers have a big role to play. I'm a grandmother now. My oldest grandson is 7. So I have a responsibility to make sure by the time he is an adult, he will take responsibility for his sexuality. So I think there's a role to play in education, and not just in the spaces, but even in our homes. Parents are a primary responsibility of teaching the next generation what they do with themselves. And I think it's a role that we're abdicating to schools and to others. And we have a role to play there.
Okay, I'm going to.
Actually, John, my question was very similar, but I wanted to come back to the King Holmes study that you did. And I wondered, what would be the next question you would probably lead on that this time. But I think one of the big questions for me as an STD doctor, it's always been, BV has always been sexually associated, not sexually transmitted. And I think we always thought, it's anaerobic bacteria. They can't be really transmitted because they don't survive long enough. But for me, that's really one of the crucial questions for the microbiome agenda. Really work out, it's clearly there is some sort of sexual transmission or colonization. And in that sense, again, the partners become important, I think. I mean, through the EPT work we've done, the dynamics are just incredible. When you interview the women about their interaction with men when they come home with treatment, it becomes a joint problem. It's not just a woman's problem anymore. And at the end of the day, I think it's about empowerment. So thank you.
And it's very late in my housekeeping, but just for the interest of the people online who may not be familiar with all of the friends in the room here, just able just to introduce yourself and your affiliation. And Val, you want a question? Oh,
okay. Is this on?
Yeah.
So hi, I'm Disebo. I'm from Caprisa Vulindlela. And I was completely blown away by all three talks. Thank you so much. That was amazing. Last night I made some last minute changes to my slides, removing, the focus, the main focus away from HIV prevention and LGBT. After listening to your talk, I really wish I hadn't. That was so amazing. I recently attended an investigators meeting with the Matrix group, and they have an excellent pipeline of prevention tools that really have great potential to prevent infections in women. And in the investigators meeting, there was no real talk about the vaginal microbiome. It's written into some of the protocols, but it's always been an afterthought. So maybe my question is, how do we bring the microbiome to the forefront of HIV prevention? It's got the potential of undermining all the work that is currently being done. So it's so important to really think about it as not as a side project or an afterthought, but as something that is crucial and critical in preventing infections in women.
Absolutely.
I'll just pick up. I think you've just answered it. I think that's exactly it. We don't put it as an afterthought. We put it as a central component, and list it as one of the real sort of investigational questions. I love the idea of piggybacking on, we know there's a lot of money in, well, maybe not as much, but there is more money in HIV type research than perhaps in this side. So piggyback by all means, but let's really advocate to have it as a central theme. I know Sharon's got some thoughts about it.
Well, yes, I was just going to add similarly, and I had mentioned to you first thing this morning that we really need to work on this pull through of the impact of vaginal dysbiosis on risk of HIV, on risk of other sexually transmitted infections, and on risk of adverse pregnancy outcomes. It's the near-term goal to treat bacterial vaginosis and prevent recurrence. And we need to do that for women because women deserve that. And we really need to see impact on these other sexual and reproductive health outcomes. And so we need to start working on that pull-through piece.
And Val.
So thank you very much. I'm Val Mizrahi, the former director here of the IDM. It's been an inspiring morning to hear 4 powerhouse women present, so thank you. I guess my comment is to really reinforce what LGB has said around the necessity of discovery in Africa. This is not a luxury. This is an absolute necessity. If we are going to fulfill our potential, it's not enough for us to take inventions from elsewhere and apply them or try to apply them or
test them. I would maintain that the way that we are going to develop is to really pay critical attention to bringing African researchers into the discovery space. And I want to pay credit to the Foundation for investing in a couple of initiatives. One of them in this building downstairs, the African Microscopy Initiative, and many others, the Geyser Initiative. This is not a luxury. So please, anybody who's in this room who has agency, who has sway with funders, I think that this message needs to be one of the compelling stories coming out of this meeting. Discovery must start here, and we need to be engaged from the get-go. And this is coming from me as a basic scientist who's tried to enforce this message, but I think the next generation have to really take this on in a big way. Thank you.
I wonder if I could just add to what has been said, because I think your message is really loud and clear. But I think the message also needs to go to our own governments. When we talk about issues of decolonization, our education systems need to teach the next generation to ask questions. We have too much education that is didactic in terms of informing and asking our young people to reproduce what they have been told, rather than teaching them to ask questions and innovate. Absolutely. And we put down people who ask questions as if they don't know, and yet they're the people who are going to make the discovery. So I think the message to our governments to think about our education systems, to allow our young people to innovate and think out of the box is very critical.
Yes, yeah.
And we have the final question for the session from very valued collaborator, Margaret.
My name is Margaret Passmore from North Carolina, local project Zambia. I just wanted to contribute to not at all.
Apologies for that. Sounds great. My name is Margaret Casaro. I'm from the University of North Carolina, Global Project Zambia. And I just wanted to contribute to the discussion that Disable brought, how not to make the microbiome question an afterthought. Just speaking about my experience in participating in the vaginal microbiome consortium, we as a group are more of clinicians, epidemiological, clinical research, but we are now venturing into looking at the outcomes that we have. How are they affected by the microbiome? And my point is, help us to build capacity to be able to do that subcellular work, moving from what we see phenotypically. Thank you very much.
Jo-Ann.
So I'm going to close this session with gratitude.
I wanted to make one additional comment to amplify the message of the importance of the African contribution to this effort. It's not just about provision of biological samples. It's not just about providing clinical trial sites, test things in this population, but it's really about contribution of the diversity of thought, diversity of cultural background on which we need to implement any product that gets developed. We can't do it, any of us can't do it as a single entity or a single geography. We need to do it as community if it's going to actually work.
Yeah, agreed.
So I just wanted to end off with the cryptic fluffy lactobacilli you got as a present, which was made by my mother. But Linda-Gail alluded to a really powerful collaboration we had with our other project partners, really key project partners on the Vaginal Microbiome Research Consortium for Africa, is Linda-Gail and the Desmond Tutu Foundation and all the team members I can see there sitting in the audience. But 2 of You Choose isolates went into the 15 strain product. And this is UC 101, Jacques. And the purple one is UC 119. So I'm just sending some African microbiomes home with you to love. And then before we close, I just wanted to say one of the housekeeping things I was amiss to introduce is Sonia from Graphic Harvest. And You'll see Sonia creating a graphic summary of this meeting over the next 2 days. And at the end of it, she'll talk us through the summary, and we'll be sending everyone home with a very high resolution image of that. And then my last thought is I would be amiss if I didn't welcome Claudina Lutz from our Department of Science and Innovation. We're very grateful to have your presence in the meeting. And I think you missed my gratitude at the beginning. So I'm just, no, it's fine. Yes. And with that, I wanted everyone to please go upstairs, have some tea, get some refreshments, and then be back here at 11 o'clock for our next session. Thank you.
Thanks, yeah, that's my Christmas artist.
Exactly. Thanks so